Welcome, everybody. I'm Shannon. It is the top of the hour here, and we're going to get started in just a minute. We see people that are still joining, and when I see that number kind of calms down a little bit, we'll go ahead and get started. So I anticipate maybe in about a minute or so, we'll go ahead and get started. So appreciate your patience, and we'll get going in just a minute. All right. Folks are still joining, so we're going to let them join us here today while I introduce myself. Welcome everybody here on this Wednesday afternoon. It's 5 o'clock on the East Coast. So whatever time where you are, welcome. I appreciate you all spending some time with me. Today we're going to talk about a collaborative care process and what it all entails and what it all means and how to do it and what are the pitfalls that we run into. And everything you're going to hear today in our conversation, there's no new concepts, right? So you won't be taking a whole lot of notes during this. We do have the handouts that are available for you there in the side panel. And we're going to go through some housekeeping in a minute, but as people are still joining, just set the stage here a little bit. This collaborative care process involves a lot of different elements that you as an evaluating clinician and as an assistant can take part in, and what makes it collaborative and what makes it useful and helpful to folks in the post-acute environment is when it happens. When does this collaborative care process happen? And we're going to get into that because I think that's where this kind of rises and falls, where the decision points are, when are they made, and when they're most helpful. So, okay, I think we've kind of reached the point here where most folks are going to be here. So here in our housekeeping slide, I'm going to let you know that the OTs and the OTAs who are here looking for continuing education for AOTA, there is at the end of this in an email, as well as through this QR code here, there's a 3-question quiz that you have to pass within a week of taking this course for you to receive credit. So once we receive that passing quiz from you OTs and OTAs, Shiloh, who is our assistant here with me today, our executive assistant, she will then email out your certificate. So that SurveyMonkey is available in your handout, certainly if you download it, the QR code, which will show again at the end of the presentation, and then through an email. For you SLPs who are out there, you are going to be, if you want ASHA continuing education, you need to submit the ASHA participant form, which is also under the handout section. Fill out that bubble sheet, which we all know so well, and send it back to Shyla here within a week. You see her email address there. You can attach it to an email, take a picture of it, hook or by crook, however you want to get it to us, that's perfectly fine. For those of you who are listening to my voice who are joining a participant, not through your own link, where you didn't register, but you're sitting alongside somebody who did register and you're both paying attention to this presentation now, and you do want credit for being here, the person who didn't register, put your name in the chat there, or reach out to Shyla at the email below if you need access that way, to let her know that this is that you are here listening and we can have a record of your attendance so you can get a certificate that way. And if you have any questions, we'll answer questions at the end in the chat feature or the questions section. If you want to enter your question at any point, go ahead, and at the end, Shyla will help me go through the questions and get some answers for you. So after all of that, now you get to know who I am. My name is Shannon Leem. I am a speech therapist by background, and I am a national clinical director with Aegis Therapies. And I welcome all of you here today. We have two very simple objectives that we're going to talk about. We're going to hope by the end of this, anticipate that you will be able to demonstrate the ability to identify the hallmarks of a patient-centered collaborative care planning process, and you'll be able to identify strategies to improve your collaborative process within your own care teams. Very simple, big order, but very simple directive that we're going to go through here today. So we have this larger overarching concept here. So a collaborative approach to patient care is hallmarked by the ability of the care team to consider all of the elements of the patient need at the time of the evaluation to create a patient-centric, outcome-focused care plan. So when I talked about earlier, when, the timing of all this collaboration, when does that occur? We're finding through lots of anecdotal evidence and certainly through hindsight that at the time of the evaluation is the best time for all of us to come forward and have an agreement, come to an understanding of what happens with the patient. If you think about any other environment, it's when the first parts of the care team come together and start making a decision. It happens in the emergency department. It happens in a hospital on the floor where a hospital bed is located, and the nurses and the physicians are coming in to make determinations and decisions. It happens all over. It happens in home health care. It happens in the skilled nursing facility. So if you think about it, when is that time for everybody to come together and decide what we're going to do with this particular patient, do with them, do for them, is at the time of the evaluation. So everything we're going to talk about culminates at that start of care. Okay. So the overview of the elements that we're going to talk about today, we're going to talk about a primary impairment focused assessment, and we'll just tell you what that's all about. We're going to talk about certainly the collaboration with the care team, how that happens, where it happens, when it happens, that kind of thing. Implementation of care extenders or non-skilled service providers. We'll talk about that and why that's important to think about them in the care process. We're going to talk about different service delivery options, care continuum elements, and then probably what most of you think about regularly is the care intensity, meaning how hard we work or how long we work with a patient each session. So the number of minutes we work with a patient, the frequency, how often per week, and the duration, how long of a stay. Those particular pieces of the puzzle, of the care puzzle, require some thought. And sometimes we look for the path of least resistance. What's the first thing that comes to mind? The easiest way to think of an intensity, frequency, and duration, and we long for the days where it may be a little easier to determine it, but really it comes down to certain elements, certain components, and we're going to talk about how you think of those components when it comes to intensity, frequency, and duration. And then lastly, the establishment of goals, how we create the outcomes that we want for our patients and how the collaborative care process comes into play with that. So without further ado, let's get started with what all of this starts with. Everything starts with the primary impairment focused assessment. And what does that mean? It's how we assess and address the primary reason for the environmental admission, whether it's in the skilled nursing facility, whether it's in home health. And we know outpatient doesn't have an admission per se, but they're at the time of the eval. What's the main reason they're coming to receive your services? In the skilled nursing facility, it's the primary diagnosis for the inpatient stay they're going to have. In home health, it's the primary reason for the home care certification period, the CERT period. Why? What came about? What's going on with the patient medically that requires all of these services to now descend upon the patient? And when we throw a dart and hit that diagnosis or that primary reason for this stay with the proper assessment tool, we have a better foundation for improvements to function, better foundation for establishing functional goals, better foundation to show the change over time that our insurers, primarily Medicare, look for and hope for when we say we're going to be presenting ourselves to solve for some deficits that have shown themselves. We anticipate that a change should happen, or we hope that a change will happen. And with that, when we have a good foundational assessment, that's a little more obvious. And this primary impairment focused assessment is sensitive to the presented deficits. So while having a standardized assessment or elements of your assessment routine that are standardized, right? An oral MEC examination, I'm a speech therapist, as I said, so an oral MEC examination doesn't matter necessarily who I'm seeing. I do a cursory look-see through that. I do a cursory oral MEC, so that's a standard element. It's not necessarily, doesn't depend on the diagnosis I'm seeing the patient for. I do a quick examination. That's what I mean by a standard assessment element. This is different than that. This is an assessment tool that is now sensitive to this patient and this impairment that I'm seeing, or this primary diagnosis that the facility is using for the admission into their skilled nursing facility. And in many cases, we have to have support for that. The facility for billing needs to have support for that primary code to show that that's a good reason for why they're here. They're here because they've got difficulty breathing. They've had a recent musculoskeletal injury, that we've got a neurological impairment. If the facility is raising that code, that ICD-10 code, that diagnosis up to the level of here's the reason why we're in the facility, the patient's in the facility, then everybody then has an assessment that supports that particular diagnosis. So it serves the facility well to show, yeah, we were right. They're here because they've got this problem, this diagnosis. So it supports the overall certification period, the overall admission that's going on. So what do we mean by it? So I chose just a few here under a few broader umbrella diagnosis elements to show you what I'm talking about. So from a respiratory standpoint, if the primary reason for the SNF admission is respiratory in nature, pneumonia, we've got COPD, something along those lines, emphysema, that we want a portion of our assessments to have these components to it, to have a VRI, the ventilatory response index, where the patient has to count to 15 and how they count and how hurried it is. They get a particular score, how many breaths they have to take, right? That has a respiratory component to that assessment tool. The Borg, perceived exertion, that's a supportive concept for respiratory impairment, for endurance. Breath support, respiratory rate, chest expansion, how the patient is able to use airflow to support their functional mobility and their ability to take care of themselves, or for communication for that matter. Coordination of swallowing and breathing for the speech therapist. So those elements support the primary reason for the admission. So they can be divvied up among the disciplines. PT can do some of these, OT can do some. Certainly all of them can also do all of these assessments, especially if they're being done across time. PT is evaluating in the morning, OT is evaluating in the afternoon, speech may be evaluating on a different day. To that extent, you can have different scores, different potentially, for this particular patient, and that would provide you information when we talk about collaboration. From a cardiac perspective, you can do heart rate, blood pressure, the patient's recovery rate, how long does it take their pulse to normalize. If it's elevated after an activity, that period of time is important to know. The short physical battery test is also a good cardiac measure for this particular patient. And again, before, during, and after activity are important timelines for some of these cardiac measures. Same thing for respiratory. Before activity, after activity is also really important. Musculoskeletal tests. We have the LEFS, the lower extremity functional scale. A gait analysis is important for a musculoskeletal diagnosis. From a cognitive standpoint, we have the Allen Cognitive Levels. Then we have the MoCA or the RIPA-G, the BCAT. Any of these are perfectly appropriate to help determine the patient's best ability to function, and supports a cognitive element to the admission criteria. For a neurological impairment, we've got the 2-minute and 6-minute walk test, modified sensory assessments, the modified Barthel. So I think you're getting the concept here, that we want a diagnosis-specific assessment tool, an assessment that hits that primary reason in some form or fashion that supports it, so that you can have a foundation for change in function over time. So now that we have the evaluation, everybody's done their evals, and we're all now going to come together and have this discussion. So how does this happen? So we're going to go through the who, what, where, when, whys, and hows of collaboration. So the elements that we're going to talk about in here, especially in the what category, what is collaborated on, we're going to talk about in more depth later, but I wanted to set the foundation early on here that collaboration is extremely important when it comes to establishing a care plan that is patient-specific, patient-centric, and has the forward thinking of the entire care team taking into consideration, so that we have unity in the decision-making process. So who is part of this collaborative team that we're talking about? So who's involved in this? Certainly we have the evaluating therapist, PT, OT, and speech. You certainly want to involve any therapy assistants into the collaborative process to determine if there's any competency gaps that might happen here. Now that you've assessed this patient and you determine the interventions to some extent that you're going to want to deploy to facilitate change with the patient, you want to make sure that your assistants have the skill set to be able to perform that. And they can address that appropriately. You likely have an understanding of that, but you may want to involve them and say, hey, I've noticed in this evaluation, Mr. Jones has this really unique thing. We're going to try this intervention. Have you ever done this before? It might not have ever come up. So you want to bring them into the discussion as well. The facility social worker or their transition planner or discharge planner, you're going to want to have a discussion with them and pull them into the conversation. Certainly nursing is a component and a needed discipline to involve in the discussion for any overlapping or overlaying impairments that's affecting their transition or any interventions. You're going to want to know what they have to focus on with this particular patient as well. And in that way, you can help support that through your interventions. Not a duplication, but a reinforcement, knowing that nursing needs something to be able to be achieved, whether it's health literacy, whether it's condition management, right? Something the patient needs to know and understand for a discharge home. You can reinforce that throughout your care plan process, or throughout the care process. So knowing upfront what nursing is going to want to be working on with the patient is important to know. So what is discussed? We've talked about some of this already, but these are the things we're going to talk about today. You're going to talk about any functional, so as the team is meeting here, you're going to talk about the functional deficits that are affecting performance. So most of you are going to come to an understanding of, yes, he has deficits with bed mobility. We've got issues with transfers, ambulation, right? The physical attributes, the cognitive elements, the communication things that most people can see, the functional deficits that are easily identifiable to the lay person. And then the impairments, the underlying impairments that are causing that functional deficit. That's the skilled portion of your assessment. Functional deficits are usually, can be identified. Nursing can identify functional deficits. The patient's family can probably easily say, hey, Bob can't walk very far, right? So functional deficits are usually not skilled in determining. What's determined through skilled analysis is the impairment that's causing that functional deficit. And in this collaborative care process, all of you are going to be able to determine, okay, these are the impairments that we see that are creating this, whether it's strength, whether it's balance, whether it's breath support, whether it's pain. Pain can certainly be an element. So those things are part of that collaborative care process. We want to know at the time of this discussion the anticipated discharge environment. We're going to talk about the uniqueness of those different decision points. A care extender implementation, and what is a care extender? Then we're going to talk about care prioritization, or the priority of the disciplines entering into the care plan. You're going to make a determination. Who should be involved now? Is this a PT speech should be involved now? OT takes a step back. Is it OT in first? Speech comes in second. PT probably doesn't need to do much more than the eval. All of that is part of that care team discussion when you determine what are the deficits, what are the scopes of practice that cover them, and who has the skills to be able to achieve that change. Then we're going to talk about determining through the collaborative discussion, the frequency of the intervention per discipline, as well as the intensity of the disciplines and intervention per session per discipline. So you don't come to the collaborative discussion with your frequency, intensity, and duration already set. You're coming to the discussion to determine your frequency, intensity, and duration, because determining that is part of the collaborative discussion. You don't want to come and announce, you want to come and discuss, okay? And then the duration of care, and then any group interactions or group classes that may be offered in the facility for practice, for regular intervention, for skilled service that might be happening. Determining that at the start of care helps set the foundation for those real life and really unique opportunities for the patient to participate in that kind of a group activity with their peers. So where and how does this collaborative discussion take place? So it can happen in person, right? All of you could wheel your chairs together in one spot and have a little conversation with the patient. 5 minutes, 6 minutes. It could take place like that in person. And many of you probably do that. It could take place remotely, meaning the therapist that did the eval who came over from another facility is not available at the time to be able to chat with everybody in the moment in person, but they're going to phone in and have a conversation with the rest of the care team to discuss it. So that might be a remote way for somebody to give their information. It could be through HIPAA compliant messaging systems. Here at Aegis, we use Teams. And within Teams, care teams can mention, okay, so-and-so for a particular patient, these are our thoughts, these are our elements we need to discuss, and it can happen through that compliant messaging in a time when everybody is able to weigh in. So it may not happen live, but it's happening through the text message where decisions are being made. It could happen through a DOR or another facilitator in the facility. The evaluating clinician may say, you know, these are the things that we need to discuss. Right now, I don't have a way to get with the rest of the care team. I'm going to be unavailable. So here are my thoughts, and the DOR or the proxy may take that information and then be part of that care team, knowing what that evaluating clinician had in mind and where those decision points lie. So here's where one of the goals was for you to help establish or facilitate this care collaboration process within your own team. So what if you have a PRN evaluating therapist not in the facility during peak therapy times, right? You have a weekend therapist that comes in and the other disciplines aren't there to have this live interaction. Or you have a therapist that comes in from 4 to 7 and does things in the evening, and they do the late admissions, or they do reverse ADLs, and then you need have, they're not there. The other clinicians aren't there as well. So that's how we talk about this remote. What if you use telehealth options for evaluations? How do you pull that telehealth evaluator into the conversation? And we mentioned the weekend, they're not all done at the same time. So you want to anticipate whatever the flow is for your team, anticipate where these decision points might need to be made now before you run into them and you need to have this care collaboration discussion. So determine what's the best method through which the team can have this collaborative interaction, this communication, right? However it happens is going to be right for your team. It's not how it happens, it's that it happens is what makes it important. So when should it happen? We've talked about it should happen at the time of the evaluations, ideally before the clinician requests any physician orders for the frequency, the duration, or the interventions, right? Because you're coming to the team to determine that, as opposed to telling them what you've already decided. You want to have an agreement before you go and request those particular orders. You can have them at the time of a status change. I think this is where already we're already deploying this. Something happened with Mr. Jones and everybody kind of comes together and says, hey, what's happening? What do you know? What do you think's happening? So I think this is already happening. So at the time of a change, collaboration should happen. And certainly a change in any of those things we talked about, whether it's a new assessment we think a discipline should do, a change in frequency because of this change in status, a change in minutes, an addition into a particular group because of a new diagnosis or a new thing has occurred for the patient. So those things also come into play with a change in status. And certainly collaboration should take place in preparation for discharge. And I think also this is also what's happening. So, and honestly, I think in some cases that collaboration is happening, the majority of collaboration happens really close to the end of care, right? Everybody comes together and says, okay, we're coming to the end. Did you get everything you need? Is everything set, right? So that collaboration is happening at the end. And then sometimes elements of all of these pieces are happening at different times during the patient's stay. That determinations of when to use a care extender is not happening at eval. It may be happening 2 weeks in. Entering into a group class is happening 3 weeks in as opposed to at the time of the eval. Shoring up the discharge plan isn't happening at eval, but it's happening later on. So many of these elements are happening at different times, but if we put them all at the time of the evaluation, we have a better chance of all having an agreed upon approach to go with the patient. Why should we collaborate? And this actually came from a great article. I put the link in here. Collaboration should occur because it provides better problem solving, peer learning. I absolutely thoroughly enjoyed my times when I would sit and listen to my peers discuss what they're seeing with patients and how it's manifesting itself. And then me determining what parts of my skill set can assist with what that discipline is needing to have solved for functionally within mobility or from a self-care perspective. And then conversely, I liked sharing what I was seeing so that both of those other disciplines can support me in my care process. So peer learning was real high on my list. You get a shared purpose. We all have a common goal. We're coming together to facilitate a change with this patient, and it really has, it can have a profound impact on the patient and on you as a profession. Innovative treatment approaches, when you all kind of come together and you, especially when you're working with a new team member, you hear about new things, new assessment tools. I remember working alongside some speech therapists who would come in and say, have you ever done this particular test? I see you mentioned Mr. Jones had this problem. Have you ever tried this test? And I'd say, no. And they say, yep, we can do this. And it was a great learning opportunity. So I really appreciate having those moments in time where you can listen to your peers. You get an agreement on the care trajectory, the coordination of care delivery, certainly goal development. Everybody has an understanding of where we're going with this particular patient, and it avoids duplication. CMS, if we're going to talk about the granddaddy of all the payer sources, CMS likes to avoid duplication. If one discipline can determine something and do something, then they prefer to have one discipline doing that to avoid overlapping and have waste when it comes to spending for the beneficiary. Now that doesn't mean duplication isn't talking about reinforcement, right? I talked about reinforcing goals. That's not what we're talking about. But working on the exact same thing with a patient when PT and OT are doing the same thing. CMS prefers when one discipline can hold and own that, and the other is working on a also very important element, and we don't have that duplication where the beneficiary then has a benefit that's being paid for two different things or the same thing across two disciplines. So care extenders, what is a care extender? So a care extender is an augmentation of the skilled services provided, right? It can be a CNA, an RNA, which is a restorative aid. It can be the family. It could be a friend. It can be a paid caregiver from the outside. It can be a rehab tech. It can be activities personnel. So it's somebody that can provide services that are not skilled, right? They don't need the license and the degree of a PT, an OT, or an ST to do with a patient. They're typically repetitive. They're doing the same things over and over. It's practice. Where the patient knows how or can transfer or can ambulate, but having especially if you're working on distance from a PT perspective, sometimes we see this where PTs will want to increase the distance in which the patient can ambulate. And there's not a lot of skilled cueing or elements that go along with that. All it is now the patient just needs to work on their endurance to walk extra feet, 5 feet each day extra. Just to increase distance is not a skilled service. That is a perfect example of where a non-skilled extender, a care extender, can come in and perform that task to help improve and practice to go further. When there's no real skilled component to it, it's just extending that distance 5 feet each day. And it's not, most importantly, a care extender is not a replacement for skilled services. A rehab tech cannot perform skilled service. They cannot be switched for a PT, an OT, an ST, a PTA, or an OTA. Those disciplines provide skilled service. When it's no longer skilled, it can be part of a care extender, or if it's practice. CMS says when the services that are provided can be taught by a non-skilled person or can be completed as an independent program, they are not covered by Medicare. So take a moment to think like what is something that a care extender can do. So once care prioritization has occurred, so we've talked about what disciplines are going to be involved, the evaluating therapist can determine the treatment elements that can be safely delivered by a care extender. Now, it may not be something that happens on day 1, 2, or 3, but maybe by the end of the first week, the end of the first 2 weeks, now we've got to a place where the patient's able to facilitate and do things in practice. Now we want to involve that care extender to do it. And one of those things can be practicing sit to stand, things that are repetitive, right? Transfers, getting up and moving from one surface to another. Lower extremity or upper extremity strengthening or resistive exercises, something that's repetitive. And swallowing or oral motor exercises, that's another example that a care extender can assist with. Repetitive cognitive or memory exercises, repetitive endurance activities, and care delivery support when another individual is needed for safety. An extra set of hands is needed, right? It doesn't necessarily have to be a co-treat with another discipline. You might need those hands just for facilitation of safety, and that can be a rehab care extender. So let's look at skilled versus unskilled. Sometimes this is where clinicians want to know what's the determination. So on the left side of your screen, we have an unskilled statement. Unskilled but important. It has important information in it. It's important information to have in the chart. The patient ambulated 50 feet with a wheeled walker and minimal assistance with verbal cues for foot clearance. So many might think verbal cues there intimates a skilled service. Maybe not necessarily, it may be pick your foot up, John, when you walk, right? So once you've established that the patient has a foot drop and they have difficulty with foot clearance, and Bob responds, or John responds to the cue to lift his foot, it no longer becomes skilled for that cue to be said over and over again while practicing, right? So that's why that's unskilled there. So on the skilled side, we have gait training with manual right hip facilitation during stance and graded cueing for increased awareness of right hip flexion and toe clearance during the swing phase. He required minimal assistance to maintain an upright position. Ambulation occurred with a wheeled walker, limited to only 50 feet due to fatigue, and the modified Borg during this activity was a 5 out of 10. Which one would an aide do? The aide, or the clinical extender or care extender, would be on the left side. They would ambulate 50 feet with that wheeled walker, min assist being provided, and reminding him to pick that foot up as he walks. Which one would only be provided by a skilled discipline, by PT? That would be on the right-hand side. So you can kind of see the very different approach to how documentation might also occur. Skilled versus teachable. When do I keep it as a skilled clinician, and when can I hand it over? When can I teach it to somebody else? So tasks or exercises or techniques that will continue to benefit the patient but can be safely taught because their performance doesn't require our skill should be taught. Once the comprehension of the instructions and mastery of the teachable task or exercise or technique has been demonstrated, it can be transitioned to an independent or supervised home exercise plan or a caregiver program. The discipline, the PT, OT, or ST can come back in for intermittent reassessment of that taught program, and it should occur and it may be changed throughout the course of care to determine if any part of that program needs to be modified or progressed. And when determining if a task is teachable, one must consider whether the complexity or the variability of the task and the complexity of the variability of the patient's clinical presentation are such that only you can provide the service, or an aide can provide the service. So this next slide actually will help hit it home. If you determine that something is not teachable, ask yourself the question, why? Answering that question and documenting the details of the answer will likely assist you in explaining why it's skilled. The absence of a person to teach is not reason for it to be provided by a skilled discipline, right? The absence of a caregiver, say in the home or in the facility. I don't have a tech. We don't have a restorative aide. The absence of somebody to do those repetitive non-skilled activities does not then make it skilled for a PT or an OT to perform. So keep that in mind. Care delivery options. So we don't need to go into necessarily all of the definitions of the different treatment provisions. We've got individual, group, and concurrent. I put it here on the slide so that you can have this for future reference, but this is what I mean by delivery option, service delivery. How am I, as a skilled discipline, going to provide care to this patient? Is it because of the patient's particular presentation to me, the complexity of what's happening, certain sensory overload elements? I have to go with individual for a good period of time in the beginning, and I have a calculable, objective analysis as to why that needs to happen. Or it may be I've identified pretty quickly this particular gentleman can go into a group element, or here's how I can dovetail that patient with another patient that I've got also going at the same time. So for a concurrent episode. So these are the particular definitions. So what I wanted to make sure that we outlined were the benefits of it. What is the benefit of providing a group class? Patients by and large do enjoy having a group interaction. We are, as probably has been said over and over, we are pack animals. We are not solo travelers through this life of ours. We tend to gravitate towards other people. We want to be around other people. Group interventions is supported by evidence to promote increased patient engagement and have sustainable outcomes. It may provide a health competitive environment that can enhance the patient's engagement. It improves carryover of strategies and a durability of response. Durability of response is that sticky stuff. Is the patient going to do what I need them to do when I'm not around? So a group interaction where the clinician's attention may be divided among other people, that particular patient may need to look to others to figure out how to do, what to do, when to do, and is learning how to support themselves in that environment without relying on the clinician. So that's an important strategy to think about. It improves, group classes improve or provide an opportunity for functional communication interactions, especially when we're talking about our communication patients. It's important for us as speech therapists to have the patient be communicating with somebody other than us. I'm sure all of us out there, me being included, have thought, is the patient getting easier to understand because they're getting better, or am I just getting used to listening to John? So having that patient in a group and I'm hearing John explain the rules of a game to another patient, I can then see, can that patient understand what John is saying? And I'm removing myself from that situation and trying to, I'm no longer, I want to put an unfamiliar listener in the situation. And that's what a group can do. It's a realistic simulation of a typical daily life activity. It provides a safe environment and creates positive support system and peer support. And it increases the creativity with service delivery. There are so many different group class options, whether it's from durable medical equipment training to condition management related to a particular diagnosis that they all may share. It could be related to holidays that are coming up. Could be related to ADL. So there's such a vast opportunity to have that patient experience some of those moments. And how do you overcome some challenges you might experience in your own facility when it comes to group? schedule a group time within the facility. You post a schedule, you have appointment cards. Some facilities have pieces of paper up at the beginning of the week with the names of the 3 or 4 groups that they're going to hold that week, what day and what time, and they just start filling patients in. And as things change and patients' needs change, patient comes off and moves around, etc. But the plan is established at the beginning of the week, and there's it's easier to implement them when you plan ahead. And then knowing at the time of the evaluation that when you have the DME group that's going to happen that week, if your facility holds one regularly, you know this patient needs to go into that group because you're going to issue him a new walker. So he needs to go into that group for that week. Schedule back-to-back or overlapping sessions for concurrent. When you schedule that, it allows for that time. So again, that durability of response. Can the patient do what you need them to do when you're not right there standing next to them for every moment? So it may not be something you do at the start of care, but maybe towards the patient's moving into transition to back home or back to long-term care, that you're stepping back from care in little moments, and you can do that within concurrent to see, does the patient do what I need them to do when I'm not always around? Providing multidisciplinary communication, handing off patients from one discipline to another. We've talked about pre-planned activities, consistent group class days, different parts of the facility, using that care team collaboration, using rehab techs or other care extenders to help with group setup and group breakdown, as well as pulling in the patients, transporting patients can assist with that. Care continuum elements. So we talked about the transition plans that can occur. So what is the patient's next expected environment? Are they anticipating going home? And is that home their primary residence? Is it an AL or an IL? Is it another is it caregiver's home, a different family member's home? Is it home without any assistance? Are they anticipating that nobody's going to be in the home with them? Is it long-term care? Is that the next environment? Knowing that ahead of time, knowing that at the time of the evaluation, absolutely will allow you to set appropriate goals and have that plan across time. Knowing that a patient is going to go home without any assistance is definitely going to change your goals. It's going to really push forward some elements of safety, fall prevention, et cetera, in your care plan that you may not have if you know the patient's going to be going to an AL or an IL or home to a patient's family member who may be a nurse, right? So knowing ahead of time what those plans are helps set the stage for your goals. Is the next environment prepared for the patient? That's a really important question to ask. So any home structure changes that might need to take place. If they're going to an AL or IL, largely that you can feel assured, hopefully, that that environment is going to be prepared for them. If they're going into the same SNF, you know how to set the stage for that next environment. Is the anticipated support needed for the continuum of care? What do you anticipate the next set of services to be for this patient? Is it going to be home health? Is it going to be outpatient? What community services do you want to deploy for this patient? It might be some element of transportation, right? The patient might need to learn how to contact and set up community services. DME needs, any caregiver education. Caregiver availability is also really important to know. They may say, yes, I've got a family member that's going to come stay with me, but it's just the first 3 days I get home and then I got to go back to work and then I'm alone on day 4. That's important to know. Condition management in the next environment. I think this is a gap. I know I didn't always pay really good attention to this when it came to condition management. I relied heavily on family members, but having the patient be able to own some element of their condition. What do they know about it? What are their red zone triggers? What are the concerns, right? When do they need to know to ask for help, call for help, whether it's in the home or to 911 or to a physician? And that helps us prevent any hospitalization or rehospitalization after the discharge. So treatment intensity and frequency and duration. So let's get into this, right? What are the elements to consider when we look into determining intensity, frequency, and duration? So, for example, these are all going to be examples from evaluations, right? We examine the functional deficits. Patient's got an ambulation deficits, transfer, bathing, and let's say they've got a swallowing impairment. Then the disciplines determine the underlying impairments that are contributing to those functional deficits. Examples could be breast support, could be upper body or lower body strength problems, could be balance problems, it could be oral motor strength issues that are causing the deficits that we're seeing. And then we determined from the disciplines who did the evals, what are the disciplines that can address those particular impairments? And where does the overlap happen? So you determine the goals for each discipline. So PT might work on that ambulation and transfers and focus on the lower body strength and balance. PT or OT might work on the bathing and focus on the upper body strength and balance as well when it goes to in the bathing environment, especially when you have wet surfaces. And then we have the SLP working on swallowing and taking the oral motor strength and breath support. And now here comes the point. Okay, so we've determined all three disciplines do need to be involved, but when do they need to be involved? Now you want to determine the care prioritization of the disciplines. So we've all evaluated, we haven't submitted our frequencies, so we're looking to see who's going to be in first. Could be all three. Could be a very heavy stroke patient, lots of issues to work on. So you're going to want PT, OT, and ST involved from day one. May not be. In this particular case, an example might be PT and ST are the priority for mobility and swallow safety, and the OT will transition into care within 2 weeks following the stabilization of function from the speech and the PT intervention. Just an example of how that thought process might happen. Now, how do we determine the intensity of care? How many minutes do I need to work with this patient? So for example, here I've laid out the CPT codes that go into the different deficits and the impairments that PT, OT, and ST we said we're going to be working on here. So essentially what you're looking for is to determine how many minutes I need to provide to this patient to change the patient's status, right? To change the patient's performance in that session. When you did your assessment, you're looking at stimulability, right? The prognosis. How, because in your evaluation, you're usually easing in some treatment, right? When I do this, well, how does the patient respond, right? That's usually some element of treatment is in there. And by doing that, you're assessing how the patient responds to you. Can I facilitate a change in this moment? By touching the patient in this way and cueing them that way, does it change their performance? By adjusting the wheelchair, by adjusting the patient's bed, by changing this environment, did I facilitate a change in the patient's performance? That would be a great indicator that I can make some quick changes pretty quickly in a rapid period of time, right? You might look at what are the group classes I can insert in here. Okay, I may not need all of these minutes in these particular CPT codes because I can have the patient participate in the group that OT is going to do next week when it comes to the use of the different bathing adapted equipment, that group that's going to happen. I know I can use that with him in the next few sessions and weeks that I'm going to work with him, but he's going to have continued facilitation with that in that group. So I can pull those minutes out of my daily time potentially so I can work on other things or other patients, right? Other things with that patient or other patients in general. So knowing where care and how care can be delivered, we change the number of minutes you want to provide in time. And then determine the number of minutes needed each day to address the codes to improve function. So we talked about the CPT codes that are there. How many minutes each day do you need to be able to facilitate a change for that particular patient? And then for the frequency of care, again, we talked about care extenders, we talked about group classes. So does each step towards the goal, right? We know where the patient is today. We've established the goal in our discussions with the other disciplines. How many steps is it to that goal, right? What are the steps that I need to take? I may know it in my head, I may have to map it out a little bit, but to each step on the way to that goal, do I need to have a session with that patient? Do I need to have a visit? Do I need to have a dose of care with that particular patient? Or can some of that be practice? Can some of it be with a care extender? Can some of it be through a non-skilled provider? Can some of it be with the patient's family member? Can the patient undertake some elements of their own care through repetition in the room unsupervised? I think we've all met that patient. We're like, you need to keep moving your feet like this. And so every time this little timer goes off on your phone that we've got here, I want you to wiggle your toes 15 times, right? And knowing from our experience with the patient, you have faith whether the patient can do that or not. And then you're taking that into consideration for how often I need to see this patient. We want to consider the next environments, and can some of the improvements that I need to make with the patient be achieved in that next environment, and they don't have to happen here. What are the interventions to be performed to address the functional deficits and the underlying impairments? So knowing what I need to address may dictate the frequency. And then what's the overall acuity of the patient? Do I have any comorbidities and complexities? What are the risk factors that are going on here? What's the prognosis? What's my variance from prior level of function to current level of function? If it's little, tiny gap, not that deep in their deficits, and we've got a short stay potentially, patient wants to go home, right? So I may want to have a higher frequency of care so the patient can facilitate a discharge home to get to that next environment. And then the duration of care. Again, how long am I going to see a patient over time? It takes into consideration that next level of care. So knowing that discharge environment is really important to facilitating that conversation. All right, so now we're going to add it all up. We have a care team now that's fully involved and aware. Hopefully we have an accurate description of the patient through the assessments, outlining the patient's underlying impairments and the functional deficits that that is created by those impairments. We are all on the same page for discharge transition and the options and the needs that need to happen. We've collaborated on the care prioritization, which could change after, if things occur that move things along. Some disciplines can come in or out faster or slower. We have an objective path to treatment frequency, intensity, and duration. We have a plan for the use of a care extender, and we have a process now to include service delivery options, whether they're scheduled and planned. So through all of that, when we take time to come together and spend all those early critical moments at the time of the evaluation to have this conversation, we do all of those things we talked about earlier. We have peer interaction. We reduce duplication. We're being a good steward of the patient's Medicare beneficiary. As a Medicare beneficiary, we're being a good steward of that Medicare dollar. And ultimately, what we anticipate is that this will manifest itself in better outcomes. That when we're all driving in the same direction with the same understanding of what we're doing with the patient, it should ultimately improve the patient's performance, which is really what it's all about at the end of the day anyway. I did include a list of resources that we gathered here for this particular conversation that we had today, so I encourage you to take a look at those. And now I'm going to open it up to Shyla to tell me if there are any questions out there.
Okay, currently there are not. If you do have any questions, now would be the time to send them in the questions feature and we can get those answered.
Outstanding. I appreciate that. So any questions at all, feel free to reach out. We'll give it another minute or two. If you don't want to put your question in the chat, but you do have a question for me, my name is Shannon Leem. You see my email at the top there, shannon.leem@aegistherapies.com. For any questions about the ASHA participant form or anything in general about the course or the handout, you're having trouble getting the handout, which you should be able to see there. It's under the handout section in your banner. If you're on a mobile device, it also should have a section for handouts, which you can download to your phone, or you can email it to yourself, and then you can use it that way. But you can reach out to Shyla with any questions there. I've included that QR code there for any OTs or CODAs who want to race right now to the 3-question quiz so they can get credit for that. If not, Shyla will send that to you in an email to remind you to take it. You have 1 week to take it, and I believe 3 chances. You have 3 chances to take that quiz and pass it. I anticipate you should be able to answer it in your first go, but if some have had technical difficulties and the cat bumped their elbow and they answered a question wrong and they wanted the do-over. So we are available for do-overs if that's needed.
I just wanted to touch on, Shannon, there's a couple of people asking about PT and PTA's CEUs. We have applied for Florida, California, and Minnesota. So if you are not in those states, you would have to know your specific state's requirements and if they accept other states.
That's correct. Thank you, Shyla. Did we get any questions, or are we?
That is it.
All right. Well, I want to thank everybody for taking this hour with me to spend some time and talk about a collaborative care process. Please reach out with any questions, and you all have a fabulous rest of your day. Thanks so much for joining with us.